So first we've got Dr. Amanda Ullman, who is the inaugural professor and chair in paediatric nursing conjoined between University of Queensland and Children's Health Queensland, and a 2021 Fulbright Future Scholar. Amanda believes children should be able to receive medical treatment in hospitals without harm. Her research focuses on improving the most common invasive procedures in paediatrics, the insertion of the IV cannula. Thanks, Amanda.
Oh, there we go. Hi, everybody. It's an absolute privilege to be with you all here today to talk about a project that I feel so strongly about, and I'm even joined by some of the people that helped us in this journey to get to the point where we have some, hopefully, some really practical recommendations that you can take back to your practice after today. So I personally think that Don't Forget the Bubbles is all a little bit magical, but we are going to talk about MiniMAGIC, and MiniMAGIC stands for the Michigan Appropriateness Guide for Intravenous Catheters. Today I'm going to talk to you about why we went about doing MiniMAGIC, what it is, and how we developed these international clinical practice recommendations on the selection and insertion of vascular access devices. So, first we're going to think a little bit big picture. The reason why I was driven to start to think about this is about decision making. You think about, you guys in the room make how many decisions every day? You are the super decision makers of Australia, of the world. You take complex information and you apply it to individual clinical situations at the drop of a hat. You make these big decisions that are going to really impact the quality of care or that child's healthcare experience. Will we admit this child to hospital? Will we not admit this child to hospital? But we also make 1,000 tiny decisions. Today I didn't have to choose what to wear, which makes me very happy, but we also do have to make other small decisions. But what we do know about decisions is that quantity does not equal quality. The more decisions you make every day, the more complexity of that, we do start to develop decision fatigue. And what we also know about decision fatigue is apparently it makes you touch your face if you look at this on Google Images. And so that's a bad thing in a COVID environment. But we also need to look at providing resources that can help you with this decision making. So yeah, so that's how I actually was my gateway drug into research. I wanted to provide good evidence-based information to make your decision making burden smaller. And when I was thinking about the boring things that I would want to focus my entire research career on, I asked around and talked to our patients. And what do they remember about their healthcare experience? Most often, it is the procedural things. It's the moment that they were taken into that room and a whole lot of people helped you get that IV in, whether it's on the first time, the second time, or the third time. And that can really direct and highly influence their healthcare experience and their engagement with healthcare as a whole, how much they're going to trust us with other parts of their healthcare journey. So, but it is simple. When I talk to my mum about what I do for a living and I say I take care of intravenous catheters, who's like, oh, you mean those tubey things that you put in the hand? Yeah, you would think it would be quite simple. Of course, there is a lot more to intravenous access than one little thing that goes into a child's hand. I went on talk about rabbit warrens from the previous thing. I went on a bit of a rabbit warren to understand how intravenous access has become more and more complicated over time, and found out some very disturbing information about the Pope in the 1400s receiving the blood of 3 young boys to see if that would make him better. Apparently the first recorded history of us giving intravenous therapy. Something about Sir Christopher Wren experimenting with pigs' bladders, which is also a little bit scary. But the thing that really changed it for us was the invention of plastics. Plastics meant that we could develop basically what you see today and you may use tomorrow. So the plastic cannula with a metal stylet that you can insert. By the 1950s, they were commonplace across healthcare. And from there, we got more and more brave and ambitious, and the technology sector, the invention sector, came to our aid. And it was all quite driven by clinicians. We saw that central venous catheters, for example, the first one that we know of that was used, was actually developed because a child had gastroschisis, and we need to work on how to administer more complex therapies. So that was a paediatric decision. The other big paediatric innovation happened in the 1990s, where a paediatric surgeon got so sick of people like me calling them at 2 a.m. for more and more lumens that they invented a double lumen central line. So apparently nagging works. That's what I took from that story. So the technology has grown. What we now know is that we have a range of devices now available to insert for a range of indications. We also have a range of insertion technologies that we have to select whether we're going to use ultrasound or use near-infrared on that baby, on that adolescent. We have to decide if we're going to insert it in their subclavian, in their femoral, or we're going to choose to insert it in their foot, in that lovely, juicy antecubital. And we have to make that decision normally quite quickly because we have to go on with making other decisions and other decisions and other decisions. You would think then with this technology arc and this rapid advancement, we'd be really getting quite good at it. Unfortunately, we are better than what we were. There's no more popes and getting human blood that I'm aware of, but we aren't as good as we could be. I would consider this case study, it is not a case study, sorry, this is a true summary of a meta-analysis and an international point prevalence audit. This is how we know that peripheral IVs currently perform in the most simple of our children in our healthcare system. So this is an uncomplicated child, a child with no previous comorbidities, who needs about 7 days of IV antibiotics. So I would there's probably one of those children in every tertiary health facility in Australia right now. So you think we'd be very good at this, but this is what this child will experience. They'll need at least 7 peripheral IV insertion attempts. They'll need at least 3 peripheral IVs. And this means that their antibiotics have been delayed 4 times. Every time that IV has failed, another IV has to go in. So they definitely aren't getting the best of healthcare in this moment. But what about the real children in paediatric healthcare? I don't know many simple children navigating tertiary paediatrics. What about if they require a central venous catheter? Surely this is where we bring out our big guns. This is where we do really well. Again, based on meta-analysis, local data, and international prevalence studies, we know that around 1 in 10 of these children will experience a bloodstream infection. About 1 in 5 will experience a thrombosis associated with that central line, and about 1 in 3 to 4 will have that central line completely blocked in the middle of their treatment. So that shows to me healthcare-associated harm. It also shows that it's not doing what it's meant to be doing. And what I'm really worried about is, I know that, don't forget the bubbles, I'm not meant to show slides like this. But just allow me one geeky data slide, which is a Kaplan-Meier, that this is a Canadian group that's been really brave about looking back at how central line dysfunction impacts survival for their most vulnerable group, which is their kids with cancer. So they've looked at brain tumours and a few other specific diagnostic groups within cancer, and each of them has shown the same story. If their treatment, their time-sensitive treatment, is disrupted due to their central line becoming blocked, then it is associated, not causality, associated with a significant reduction in survival at 5 years. We can't fix a lot of things about paediatric healthcare fairly easily, but I would argue that some things, some occlusions of these central lines could be fixed relatively easy with some good practices and some really good decision making. Hence, so this is a wider goal for my research program on something super simple, which is that I believe that children should get their treatment without being harmed by their IV. And when you layer into there's some pretty ambitious things actually, because I'm saying all of the treatment that they need. That means timely, appropriate treatment, and they should not be harmed. That's their infections, their blood clots, their extravasation injuries. That's all the layers that could happen from that device dysfunctioning. And with this project in particular, we decided we wanted to provide easy, simple decision support for each of you who need to make each of those decisions at the bedside. So we wanted to help you make the best, safest, most appropriate decisions when you are selecting between devices, when you're selecting between device characteristics such as lumen numbers, and what insertion technique you're going to use. So are you going to use ultrasound or other types of imaging? Sounds pretty simple, right? So lots of data out there, and the reason why we started to develop this project in particular is because of this dude who is not a magician, but he did develop MAGIC. This is the Michigan Appropriateness Guide for Intravenous Catheter, and this is Dr. Vineet Chopra. And in around 2015, 2016, he was based in Michigan, hence why it was called MAGIC, and he developed the same guidelines, the same set of rules or same set of safety measures for adults. And when he presented this to us, we were all very excited. Us paediatric clinicians went, yeah, they don't quite work for us. But then he started to show this type of data, that if you improve the safety of those decision makings based on what we already know, you will see a rise. If you increase your appropriateness, so the safety, you will see a reduction in complications, including thrombosis, CLABSI, and occlusion. So the big complications. These aren't even the smaller experience-based complications. These are the big complications. So that's really powerful information to think of to drive you to improve your decision-making. And the way in which he had gone about producing MAGIC was using the RAND UCLA appropriateness method. This is different from a usual clinical practice guidelines, which normally relies on a systematic review and that you grade your evidence and you move on. The extra information allowed in the RAND UCLA is the POOBAR. Now I've learnt that term and I'm going to apply it to everything. The POOBAR phenomenon, where you actually also take that evidence and put it through a panel. One of the POOBARs for MiniMAGIC is here today. And we also make each of our ratings based on a specific clinical scenario that allows us to think of, this isn't a generalist rule, this is a specific applied pragmatic safety requirement. So it's based on known variability within each paediatric patient and applying these rules to each of them, rather than thinking of everybody should get this dressing. Let's now thinking about this patient in particular would or would not benefit from it. And it is based on a safety premise where we're looking at appropriateness versus inappropriateness. So safety is a different word for appropriateness, I guess, in many ways, and inappropriate meaning it is not safe. The risk outweighs the benefit. And then we also allow this measure of uncertainty in the middle. So MiniMAGIC is what we came up with. If you're interested, you can look on here and you will see all of the papers, all of the protocol about how we went about doing it. We have interviews with clinicians, interviews with families about their experience of what MiniMAGIC has meant to them. You can also download our app, and we'll get to that in a minute. But the first thing here is to acknowledge our thanks for the funders. The AVA Foundation is actually the Association for Vascular Access Foundation, which means this project was funded by clinicians in the US who do vascular access for a living. So it was donated by clinicians directly to this project because they saw that they wanted paediatrics to benefit from MiniMAGIC as much as adults had benefited from MAGIC. So this is a clinician-generated research fund, so huge thanks to them. And this is the Grand POOBAR meeting that I'm talking about. So in February 2019, we flew these amazing clinicians representing a huge amount of disciplines. So 14 clinicians were flown in from around the US and Australia into snow, so they couldn't leave the room, was my secret agenda. And we went through over 1,000 clinical scenarios. The importance here was the range of disciplines that were recommended. We have cardiac surgeons, we had infectious diseases, we had pharmacologists, we had vascular access specialists. So we had those super POOBARs, but we also had the pragmatists. We had the hospitalists from regional settings as well to say, I need to make sure this works for me. And we had registered nurses who were doing things at the bedside that had to apply some of these findings. So it was an amalgamation of, I can't think of a mini POOBAR. Of both, and in the middle of this was two methodologists who actually wrote the RAND UCLA method, and the person speaking there is Manny's mum, is what she prefers to be called. So Beth was our consumer advocate who made this project happen, and we listened to her at every stage. This is the group of papers that was published in Paediatrics in a dedicated supplement in the middle of 2020. I don't know what you guys were up to in 2020. Not much was going on. If you missed it, I'll let you have it. And this is the app that you can download. And this is what I wanted to highlight, is that this is a clinical practice guideline that allows clinical pathway flows, where you select your patient as you go through. You think of their age, what they need that IV for, how long they're going to need it for. And then it gets rated as red, bad, leave it be. Don't use those devices. Green should be pretty good most of the time. a little bit of uncertainty there with some of the different devices, but we're trying to provide that clarity of decision making. This does not replace expert clinical decision making. If you have an amazing knowledge of your patient population and their vascular access requirements, you may already know some of this information. However, for our junior clinicians, our stress clinicians, the person you're trying to take that decision fatigue away from, that's what this is pitched at. It's an equity of decision-making availability. You're getting those poo bars right onto your phone. It provided with us some first practice targets. These are the things we're going to move away from, and we've been doing a lot of work on this in Queensland Children's Hospital, and the reasons why we have focused on these 5 things is because of their relationship with poor outcomes. We know if we get rid of using peripheral devices for peripherally incompatible therapies outside of an emergency situation, we will reduce extravasations. If we get rid of PICs with a less than 7-day dwell that you could do something else for, you will reduce infections and thrombosis. If you get rid of just-in-case multi-lumen PICs, you will also reduce your infections and thrombosis. More lumens means more risk. We have high-quality data on that. If we get rid of landmark insertion for peripheral IVs for children who have known difficult intravenous access, so DIVAs as we like to call them, and this means we know that in advance, we assess them using a tool and your expertise, and you know this is going to be a challenge, then use your ultrasound, use your near-infrared from the beginning, not as a rescue therapy. We also have done a lot of work to look at peripheral IV, moving away from peripheral IV for suboptimal places outside of an emergency again. So that if we know that child's going to need that IV for a period of time, don't put it in a joint because it's not going to last the therapy that they need, and it can result in extravasations and device failure. And device failure just means another device has to go in. So it's going to cause you more problems downflow. We've also developed some research targets. We've done a large amount of work on implementation locally. We've also been looking at this midline catheter group. That's the devices that are inserted in the upper arm with the tip finishing at the axillary region. And they went out of fashion. They were in, and then they were out, and now they're back in. Now, the reason why they're back in is because they're now made of PIC materials rather than peripheral IV materials most of the time, and we've understood how we should best insert them, but we don't really understand their performance, so we're doing lots of trials on that. And now we're also looking to do some work on device selection in oncology, haematology. But what I want to leave you with is this understanding of the patient experience of having a vascular access device. We recently undertook a mixed method study of 200 children and followed them as they navigated healthcare with a central venous catheter. This is not a one-way device. They go within our hospital, outside of our hospital, back into a different hospital, and they have that device for sometimes their whole life or a different version of that device. We also interviewed them and their families, and the themes that came through were that this is a fundamental part of their healthcare experience, but also they have a sense of ownership over that very simple plastic tube, and they know that it can result in harm. So lots of the resources that we develop now need to be less focused on us and to be more focused on them. So one of our big follow-on projects has been to develop an IV passport so that the patients and families can download and they can keep their information about their device. It's their information. When they present to emergency, they deserve to have knowledge about their port, about their tunneled catheter, how long it's been in, problems that they've had and the devices they had before it, and what might come next. So hopefully, that is already out there in the world, and I'm hoping that you will start to see parents, children and their families come to your institutions and present with you that data, and you see it, you recognise it, and you respect it for what it is. It's something that they care about very, very much. This is my little vanity slide. If you're interested in any of the research that we have that has been shown here today, if you click on that QR code, that'll take you to my UQ website, which everything's open access, so you can download the information. And that's my average kid. So that was my average kid that got admitted to Queensland and needed IV antibiotics for 7 days and had 4 peripheral IVs over that 7 days. And even though he's less cute now, he's 12, 13, and a little bit smelly, he still remembers those IV experiences and cares very deeply about them, not just because I talk about it all the time. So thanks for your time, guys.
Wow, thank you so much, Amanda. Sorry, I forgot to say at the beginning, if anyone's got any questions that they don't want to raise their hand, you can put them on Twitter and just tag @CodeBlueNursey and Tara will get it. I've got one question for you from myself, and then we'll go to your question there.
Yeah.
So you put up that beautiful timeline. What's the next great advancement in IV access?
Well, there's a lot of things that might be coming later in this panel that may help us find the next solution. But when we're looking at solutions for IV access, for one, we've got to have the patient, the child and the family in the middle of it. But we need to look at innovations that cross between insertion management to prevent complications outside of day one and into the rest of that dwell period. So the types of things we're talking about is what the catheters are actually made out of, how we lock them when they're not in use, and how we promote their performance when they are in use. So thank you. Dream question. Yes.
Thanks very much for your great work. How are you spreading this wonderful news with the specialties that have patients who commonly have indwelling catheters, like oncology, respiratory medicine? Because I think that they need to know, because I really love that acknowledgement of ownership of the device and the importance of the parents having that information and being able to then present it when they need urgent access.
Yeah, so the IV passport was actually, we did a co-creation approach to developing that innovation. So you might be able to tell, so I'm a nurse, I'm very consumer-centric, as most people are here today. So when we went to develop the IV passport, we actually brought all of those people into the room to help us develop it. So we brought a panel of consumers and a panel of those interdisciplinary clinicians to co-create it, and then we tested it using a mixed methods project to follow up to see how it impacted their journey. And the dissemination, well, look, we're only at the point of writing up those papers at the moment, which is one little part of the dissemination. But we're actually disseminating it mainly via the consumer networks. So we had, like, the representative for Cystic Fibrosis Australia, we had the Parental Nutrition Down Under. Each of those groups came to that meeting, and they've taken it out and they've taken it to their to their newsletters, and they put it in there. And so they're the people that give me the most feedback about this. But I acknowledge that I need to get it back to you guys and to that wider cohort to help them download it and support its administration. So looking for support on getting it out there in that way. Thanks.
Hi, Amanda. Thank you so much for that. I guess my question is, I am working predominantly in an emergency space, and if we have, children coming in with illnesses that will require prolonged intravenous access, some of those options, I guess, aren't available to us in an emergency department, where kind of a standard PIVC would be what we would immediately put in, and they've already potentially had 3 or 4 attempts at trying to get that happening in the emergency department, when we all know they're probably going to need a PIC or something more long-term going forward. I guess, how can we navigate that in that kind of initial presentation?
Yeah, absolutely. So having an understanding of where that, it's hard, isn't it? Sometimes you don't know whether they're going to need 1 day or 7 days of IV antibiotics. These things aren't always clear in emergency. So doing the best quality in that first insertion is really great. If you know that they're going to need that device for more than a day, then definitely moving away from the joint. So a good peripheral IV, even a long peripheral IV, if you have those available in the forearm, can have great performance for more than 3 to 4 days, which can be great. I'm not a fan of a PIC insertion isn't an emergency. We shouldn't be looking, that's not the indication we're talking about then. But what we need to do is, when we're doing the handover of care between emergency and the ward, that this vascular access planning is part of that conversation, to say I've got a good peripheral IV in, or I've got an okay peripheral IV in, but it's the best I could do. When they're going for theatre, they're either going to need their peripheral IV changed out, or they're going to need a different device in. So it's about partnership, as most of healthcare is, and doing the best with the resources you have available. For ED in particular, I think most EDs are really ultrasound savvy, and seeing how it can be applied for this indication would really help us make a lot of better device selection. The antecubital inserted peripheral IV is normally a sign of desperation, that they've tried everything else, and you've often gotten through some of the other ones that are available. So thinking in advance regarding that, about if you can use ultrasound from the beginning, but then that's a workforce issue, and it is a procedural support issue. So this isn't just inserting an IV. This is a complex procedure for some kids who haven't navigated healthcare. So a few different prongs in there.
Thank you so much. Got time for one more question, and then we'll move on to Brooke.
Hi, Amanda. Good to see you again.
Yeah.
Thank you for your talk. I just wanted to ask from a reporting, a clinical incident kind of point of view. So the Queensland Paediatric Quality Council, as you know, has published some of the severity assessment codes, so the SAC-1, so the permanent harm, and then they looked at the SAC-2s. And of course, it was heartbreaking because we all just assume a line is going to tissue, so we don't see that as harm, and we're not reporting it. So it's massively underreported. Now, do you think we should be reporting it more? Is it like, you know, should we get to the stage where we're like, say, pressure injuries, where, you know, this is a grade 1, that's, and everybody knows that that can go and progress, and it's seen as harm and potentially can get a lot worse? Should we be doing that? Because I think we need a cultural change here so that people don't expect that line to tissue, and that it is not okay to have 3 lines for your 1-week course of antibiotics.
I couldn't agree more, Sharon. So this acceptability that peripheral IVs fail, I mean, peripheral IVs have, I'm not going to say the number because it's in the next thing, about the failure rate for it is completely unacceptable if it's your child. If you are unhappy to have that happen to your child, therefore you should be unhappy for it to happen. But it needs to be monitored and reported for us to know that it's an issue. We have an issue when it comes to even the terminology of infiltration versus extravasation. Who here could put up their hand and say, I totally know how I would code the difference between those two? And the delay between injury and presentation for extravasation for severity is also an issue. So we've got some work to do to make some clear information available and how it can be reported. But I'd love the idea that if you see an infiltration injury, you don't just take the IV out and say, well. You do code it as a healthcare associated harm issue, because then we can see how we go over time. I'd love to see a spike in infiltration injuries because it's a sign we care about it, and then we really do see a reduction. But also have a spike of, we needed 5 attempts to get that IV in. That was a healthcare associated harm. So we need to do better at that in the future. So both of them should be reported as part of good risk and safety monitoring.
Thank you so much, Amanda.